Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Well, I guess I have our first case for us today. Thank you for joining me, Sweta and Rebecca. Looking forward to our discussions today. The first case I have for you guys is really, I think, maybe two parts because it's pretty long. So let's start off with this. Is a 45-year-old female. She has a history of having a Roux-en-Y previously and an alcohol use disorder. She last month was admitted for a question of a GI bleed, but had an EGD at the time that did not show anything abnormal. And so she was brought in with abdominal pain, emesis 6 times with spots of blood that were the size of a quarter and some dysuria. So in our emergency department, her heart rate was 136. Her systolic pressure was 181. She had abdominal tenderness and right CVA angle tenderness. Her labs show an alk phosphate that was elevated. She had an elevated lactate, and it was repeated, and it was 0.8 higher. Her UA was positive with leukocyte esterase, white blood cells greater than 100. She had blood. She also had multiple bacteria present. Because of her heart rate being elevated and her lactic acid being high, they felt she might be becoming septic. They gave her a liter bolus and started her immediately on ceftriaxone. Then about an hour later, sent her urine. She also got Zofran for some nausea, some oxycodone for pain, and it was decided that she was probably going to need admission. She was taken off to CT scan first, which showed that her bladder had wall thickening. Her right-sided collection system was dilated, and there was urothelia thickening that the radiologist said is consistent with pyelonephritis. So she was admitted into the hospital. She was continued on pain medication. An attempt was made to minimize narcotics, but she was saying her pain was 9 out of 10. So she got a dose of oxycodone, came down to 7 out of 10, but she was still writhing in pain with nausea, vomiting, got Zofran and Compazine, as well as the sucralfate that she had been receiving as an outpatient since her last admission. She also was continued on some IV fluids. GI PCR was ordered, and she was placed in contact precautions because she'd had a norovirus that was found on her last hospitalization. So they were waiting for this PCR to come back. And she was only taking in PO liquid and not eating solids. And she was definitely not doing well nutritionally. She had lost 20 pounds in the past 6 months because of ongoing bouts of abdominal pain, et cetera, and the question of hematemesis. So this was all sent in. By the way, the next day, her urocultures came back with strep group B. She'd had E. coli in the past. She continued on IV ceftriaxone for 3 days. Her stool showed adenovirus. She started having diarrhea, and there was C. diff toxin present. So this was all sent in at this time to the insurance company because she'd been switched to inpatient, and they denied her case. What do you guys think?
And how many days do we have so far on the length of stay?
Yeah, she's a 2 midnight payer in her plan, and we've got at this point in time, we've got 2 midnights and 3 days.
I mean, I feel like the medical necessity is there. I mean, I think you've got the vomiting, with the component of hematemesis. Now, it doesn't sound like it's a rip roaring GI bleed, but it does, it's still there. It does make me more concerned. You have, clear evidence of a more, complicated UTI with the anatomic features. And, she's clinically, not necessarily improved and able to go home that next day. So in my mind, you have what you need from at least what I've heard of the objective data. So I think I would go after the peer-to-peer at this point. So I don't know, Sweta, do you have other thoughts or?
I agree with Rebecca. And again, especially because it's a 2 midnight pair, where is the second midnight medically necessary? And when patients throwing up next day, writhing in pain and is difficult and not stable, we don't have urine culture results back, and having a new diarrhea where you send for the C. diff, I think there is enough to explain the need for that patient to stay the second day and require those additional services. And with the IV antibiotics, you're also getting the intensity of services, not just all the diagnostic workup that this patient required, but also have enough intensity of services with the antiemetics and IV antibiotics, especially because transitioning without knowing what you're trying to treat, and someone who already has pyelonephritis and sepsis like picture when they came in with lactate being elevated, it's not something you can treat just like a patient, a woman, especially coming into the clinic with a UTI. So that's where I think we need to make the differentiation and say it's not your typical observation case and go after with the peer-to-peer. Now, on the other hand, do I see a response coming? Well, but the patient stabilize and discharge in 3 days. Yes. And that brings me to the point. Well, the intent, again, observation period is not necessarily, okay, keep doing the aggressive treatment. Was originally when OBS and inpatient patient class came, OBS was to see, are we able to discharge patient in 24 hours? And if not, and they have continued care needs, that's where I think we need to try push back and say, that's where we need to make the determination of inpatient, not like if patient can be discharged or not. Are they too sick on day 3?
Well, the denial letter here was talking about this being a urinary tract infection, I think without the realization of the CT report that showed that this is probably pyelonephritis. And so I think that's something that the payer missed when the medical director on their side was reviewing the case. So it gets more complicated. So here's the part 2 part. So the patient stayed. On day 4, they actually had, in the 24 hours previously, 5 watery diarrhea episodes, and now on this day up to the time of notes, 4 more. So they decided that they would call infectious disease to have them discuss the case and see what their recommendations would be. So on day 5, the IV antibiotics continued, so we're 5 days of IV antibiotics. ID was consulted, and they said continue ceftriaxone IV in the vancomycin at 125 milligrams PO for even though the EIA wasn't positive, the toxin was positive, the patient's symptoms are positive, and the diarrhea is documented by nursing. It is watery, and it does have the smell consistent with C. diff. So ID is saying, yes, you need to proceed. They are recommending 10 days of IV treatment, and the ceftriaxone about 10 days of PO treatment too. So the patient continued to receive treatment. It looked like on day 6, her diarrhea was cutting down a little bit, but she was still having incredible pain. And infectious disease said continue with IV antibiotics for the pyelonephritis because we think the pain is coming from the pyelonephritis. So on day 7, her diarrhea picked back up again, the amount, and so they increased the dose of PO-Vanc and the frequency of the PO-Vanc. She had nausea but no emesis, got Zofran, got Compazine, and her pain continued through day 8. And up until this point in time, when I did the peer-to-peer, the medical director was saying this is still not meeting criteria. And I said, on day 8, our acute pain service was called. They came to evaluate the patient. And on day 9, they started a ketamine infusion. Well, then I finally won over the medical director on day 9 because a ketamine infusion was started. In my mind, that just took a lot to get to the inpatient designation on this patient who obviously was in significant distress for multiple days, requiring IV antibiotics, PO vancomycin for C. diff that was likely, infectious disease subspecialty consultation. Now we've got anesthesia subspecialty consultation. So ultimately, the payer said uncle, essentially.
Wow. I cannot believe it was the ketamine drip that was the tipping point. Like, I feel like you were there like days ago, just based on, the severity of illness, clearly failed OBS, was having multiple medical problems going on. I cannot imagine how you would have managed this outside of the hospital, lower level of care. And I feel like most of our even, the commercial payers and the Medicaid payers that I deal with would have also come along with me, even though they aren't 2 midnight payers, to inpatient. So, wow, I'm glad, I'm glad you got it though. That was crazy.
Even I'm surprised. And for this case, even if it's not a 2 midnight pair, it's a other commercial product, patient continued to require services beyond the observation period, like they like to use the term, was patient still needed to be in hospital after the 48 hours. This patient clearly does needed to stay in hospital, was symptomatic, was getting consultant input, was getting IV antibiotics, and they're saying to continue the IV antibiotics because our as per the antibiotic stewardship, they're pretty good about narrowing down antibiotics or switching to oral pretty quickly. And in this case, they're telling to continue with the IV antibiotics, and this diarrhea that's been an ongoing issue, and especially when patients nauseated requiring compazine, and they won't be able to take enough oral intake and need to stay in hospital for monitoring. Again, this is something that should have been inpatient or agreed on as an inpatient, even day 3 or 4, didn't even need to wait till the IV ketamine. Because not always these similar patients end up getting IV ketamine, but because it does take time for them to be stable enough, their symptom to show an improvement trend that we can safely say they won't bounce back. Because it's not just about starting the treatment, we also want to make sure they'll are recovering and won't bounce back to the hospital.
Yeah, and I didn't even give you guys a list of the pain medications, the number of times of the different antiemetic. I was really struggling after even just giving them all the information about the urine cultures being positive, that it was significantly resistant, that we were continuing the treatment for the C. diff, and I wasn't getting anywhere with them, including the pain medication list, until we got to the ketamine infusion. And then the ketamine infusion required a separate line, individual running of the ketamine, a continuous pulse ox monitor. The nurses were doing Q15-minute checks of heart rate and SpO2. So eventually we got there, but I was really thinking, oh my goodness, I feel like I'm dealing with somebody who maybe is doing one of their earlier cases for the payer, and they have a quota, and they think that because this was initially looked at with a UA that's dirty in the urinary tract infection, that they were going to say this is a UTI and you can't have anything but observation for a UTI, not hearing all of the other things that are going on. So I think persistence paid off here, and eventually I was hoping that I would get to the point where the payer's representative would see this is not a normal urinary tract infection. So, well, thank you for the input and for telling me I'm not crazy for thinking this was inpatient earlier than the payer's medical director thought it was. So, having said that, then I will turn it back over to you guys. Rebecca, I think you had another case you were going to discuss with us.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. AppleCom is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our next case.
Yeah, I have a second case today, and it actually pairs nicely with your case, and I think it kind of will test the waters here on our threshold for inpatient. So I've got an 80-year-old female, has a history of hypertension, diabetes, lives with her daughter, has had some prior UTIs in the past, but was brought into the ER because the daughter just thought she seemed just not quite herself. She's maybe a little weaker. Patient had some fatigue, but really no other specific symptoms. They brought her in to the ER. They did their usual battery of tests. CBC wasn't too exciting. It had a white cell count of like 9,000. BNP also showed normal electrolytes. Creatinine was like 1.1. Urinalysis did have leukocyte esterase and 50 white cells and trace of red. So looking back at her culture, she's had prior E. coli, pan-sensitive on last one, but they decided to bring her in the hospital because the daughter's just a little bit nervous. And so they put her on Rocephin and they have her go to the hospital as service. They did start out in OBS, and then hospital day 2, our team is doing their review. They find out after multidisciplinary rounds, they're going to keep the patient for another midnight because they're waiting on the urine culture. And, the patient's still a little bit weak, and, therapy saw her. She's maybe a little bit below baseline, but she was eating and drinking. Vital signs were still okay. No dramatic change in her labs. And so they went ahead because she was staying the second midnight on IV Rocephin. It was a Medicare Advantage plan, and they upgraded to inpatient. And then we did get a denial for inpatient on this case. So, we just had another UTI case, that looked very different than this one. So what do you guys agree with the payer? Have we gone too low on our threshold for inpatient for UTI in this one? Or is it worthy of, inpatient because it did have 2 midnights? So what are you guys thinking?
And did your physical and occupational therapy group actually feel that the patient was not ready for discharge, and did they document it in any way? That would be one of the questions I would have. And then what does a daughter feel specifically the patient is like in comparison to her baseline? And was that documented in any way? Is she more fatigued or is she encephalopathic? Because I found payers to be really responsive to an encephalopathy because it indicates usually the patient's going to falter in their activities of daily living. So I would wonder about those things. I would also wonder on the next day, did her white count go up or down? I don't hear anything about a fever in what you've said, Rebecca, but that would be another thing that I would want to know about. And then, is the patient still symptomatic even though they've gotten a dose of the ceftriaxone? Are they having any burning or foul smell or frequent urination? Any of those things that we could document to further show that this is an ongoing urinary tract infection in an elderly patient who has, what might become a complicated course.
Yeah, no local urinary tract symptoms, just, felt a little bit fatigued, not, no significant alteration in her mental status that, from baseline, just maybe a little bit sleepier, and no fever. But, again, the plan from the hospitals was they were waiting on the urine culture, so they were going to, keep her on the IV Rocephin until they got it back. So How about you, Sweta? What do you think? If you were the hospitalist, what would you have done with her?
Yeah, no, I think I have a similar question, especially in an elderly patient. It is not a simple UTI anymore. It's a complicated UTI. But what my questions are, what were the previous, because this patient has had UTI before. Do we have urine cultures from before? And especially if they showed resistance, it will be preferred to keep the patient in hospital to wait for the urine culture rather than just switching them to Keflex and then following up on the urine culture and deciding and calling and changing the antibiotic as needed. Because from what I'm gathering, one, patient is not septic, vitals are stable. In terms of encephalopathy, came in with weakness and some vague symptoms, but not feeling the same, but not necessarily confused or disoriented. And then PT also felt not baseline, but not too weak to not be able to be discharged home. So they cleared on their end. So then it really boils down to then identifying the initial clinical decision of keeping the patient was for this urine culture. What we can do to support that was a medical necessity. So any prior urine cultures or?
Yeah, no prior history of MDRO. And, what I'll say with this one, this is, unfortunately something that we see a lot. These are the ones I know I'm struggling with, my team's struggling with, is that we see these patients, often elderly, vague symptoms, diagnosed with UTI, and staying for at least 2 midnights on IV antibiotics until we get the culture back. So I know my PA team, and when I look at these cases, I'm always asking the same question: did they really need to stay? Like I'm kind of with the payer sometimes, to be honest. Some of these cases, like objectively, I'm seeing a very stable patient. I'm not seeing a lot of severity of illness, and I think that's where, I wanted to bring this case here as not necessarily just a case, but rather a larger group of cases that we see. And, we've worked really hard with our team to try to have them working top of license and try to get them to convert. So we're not, as PAs are not looking at all these cases. And oftentimes being on an IV antibiotic, that can be easy for them to say it's objective, I'm going to upgrade. But we are sometimes getting these cases that are really hard to overturn in a peer-to-peer. Well, yeah, they were on that IV antibiotic, but the question is, do they really? So my team actually, because we were getting so many of these, and oftentimes we were looking at them and really struggling to figure out why did they need to stay, other than the attending just wanted to know the culture results. And in my mind, that's not always the best answer. Like, do you need that? And some of my PAs are even ER docs, and they made the point, like, we frequently see these patients and we send them home without a urine culture. We're very comfortable with that. And we have a mechanism to follow it up. And so as we were starting to dig into this a little bit more, this actually has become a bigger project for us. We found that part of the rationale for some of these patients staying is because we don't really, for our hospital service, who does not have their own clinic and have the nurses and have really a good mechanism for following up some of these urine cultures and handing that off after they leave the hospital. Oftentimes just, that, as we dug into it, was oftentimes, part of a good portion of why they would stay stuck at midnight. And so, because we are struggling to get these overturned, these cases that are very similar to this, we are starting kind of a project. We're partnering with our hospitals team to figure out how can we do this better. One, if the patient's really doing okay, there's nothing objective, they're tolerating PO, they have no MDRO history, that you could probably get them on an oral antibiotic. How can we do that sooner? How can we potentially make everyone feel more comfortable with a solid outpatient follow-up plan for the culture results, adjusting antibiotics if the culture is different, and taking away some of those barriers for these, I think, really lower level admissions. So I don't know. I wanted to kind of bounce that off of you guys. We are just in the middle of starting our project, but I wanted to get your thoughts on it, and just with this general bucket of patients, because I'm sure you have these same patients too. So.
We do, Rebecca. We get this frequently, with the elderly patient who's now looking like they've got a urinary tract infection and family's uncomfortable. Sometimes the ED docs are uncomfortable. And then when you get them admitted, the medicine doctor's uncomfortable. I would say the big concerns I would have with changing just to oral, sending them home with follow-up would be, number one, I don't know if you guys have this or not, but we have a problem in that getting a quick follow-up appointment for anyone for anything is next to impossible. We are just so oversubscribed in our outpatient clinics that, not that I'm saying that that justifies keeping a patient in the hospital, I'm just saying that we have to deal with the reality of the current medical situation, which is we don't have a lot of outpatient appointments to assure that all of these patients would get the kind of rapid follow-up that they need. And then the other thing is what we've done is we have a category now when we're doing our physician advisor work. It's called observation with re-review. And that might have been the way we handled this one, would be to say, okay, it's day 2, they're staying the second midnight, they're getting IV antibiotics. We want to say inpatient, but reality is if they're looking fine in the morning and they're going home, let's call it observation. But let's say they stay because the cultures come back and there is something concerning there and a need to see infectious disease or switch the antibiotics, or patient gets worse or encephalopathy develops. So we have this new category called observation with re-review that we can document as a physician advisor. And that will keep the patient in the hospital, especially these elderly folks, and give us another day to just see how these things are going to work themselves out. That's one thing we've done. Sweta, did you want to?
And one more thing I want to add to everything that Teresa said, I totally agree, and the things that she shared, and especially because of this outpatient follow-up. But I've noticed, like you said, Rebecca, in our system too, system or units that have a good, robust follow-up process are pretty comfortable with switching to oral, discharging, and calling back if the antibiotic needs to be changed. But where we don't, so for example, our short stay unit, observation unit, we have a list that we follow. Okay, we're reading on cultures on these patients, and somebody will follow. And if there is no history of MDRO, we also have antibiotic stewardship guidelines, which help us reduce them down, that we can transition them to oral and discharge them if they're doing well. But at the same time, a lot of time pushback comes us from the other side, which is patients or families are not comfortable with those transition and have that initial mentality of like, we want to see first and make sure if the antibiotic is working or what the cultures would show. The other thing I also want to point out when it comes to elderly, our options in terms of good oral agents are also limited in terms of like in a young patient where you're trying to treat UTI with Keflex, quite commonly used, easy, but someone who, okay, was if recently treated, gives me a little bit hesitation. If was already on this repeated times, are we running into resistance issue? The other thing is elderly, it's hard to give them fluoroquinolones with the side effect profile, or if they already have baseline poor renal function because of age, something like Bactrim, where you will be worrying about their potassium going up or creatinine. And again, did the clinical team had good enough option to safely transition to oral without knowing the culture results? And if they did, and this patient didn't have too many comorbidities, then I think it's hard to argue those cases. And that's where a lot of times our what we call our antibiotic guidelines that we have in place for all the common infections help us, and they are pretty well defined in terms of individual, like complicated UTI, pyelonephritis, and when to transition them. And that helps us when those are referenced as well in the documentation. Like what was the rationale to keep or discharge on oral if it is a discharge and things don't go as we expected, which is patient turned out or came right back, then they can say, we followed the process, we followed the standard of care, and but still these were the limitations or things still can happen. Because I think we want to make sure when we are bringing these new processes to try get realize, okay, does the patient really need to stay? If not, the discharging, are we following the standard of care?
Yeah. And definitely with this work, we're going to be we did a big case review, just taking a look, and we feel like probably about a third of our simple UTIs, not the complicated one, the third of the simple UTIs probably have opportunity for a sooner discharge and not necessarily waiting for that final culture result. So we feel like we've got some room to go after this. So we are definitely going to be starting with education and going back to basic antibiotic stewardship principles, and then working with our hospitals team to hopefully create just a better follow-up process, because I get it as a hospitalist, if you don't have a nice structure for that administrative piece of following up, who's going to make sure we transition antibiotics if they are having trouble, or I can't get them into the PCP. I do think your comfort level with sending someone home before that culture is back is a little bit harder. So I'm not sure yet where we're going to go with this. I mean, those are some of our ideas, and we'll see if we can make some ground. But just seeing it over and over again, my team just felt like we had to try to do something. It feels like there's a good opportunity here, because we really aren't getting it with our payers. And a lot of these we do end up leaving as OBS because we cannot get them overturned. And, as you said, I'd like, continued OBS. I know we don't like that metric for our Medicare patients of having greater than 2 midnights and discharging in OBS, but I still feel like there are some that are going to fall into that bucket, unfortunately, because of situations like this. So thank you for both of your thoughts, and I'll have to keep you posted if we get anywhere with this project. So
yeah, we'd love to know, Rebecca.
Yeah.
That's a wonderful idea, because this comes up for sure.
Excellent discussion. Those were really good cases, Teresa and Rebecca. And we got to see the two spectrums of UTI. That was lovely.
Yeah.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.